It's good evening, everyone. And at the outset, I would like to thank Dr. Gunjan and the whole Edusurg team for giving us this opportunity. So I'll be speaking on the principles of management of chronic pancreatitis. But I think it's very difficult to get into the depth of the management of chronic pancreatitis in just 10 to 12 minutes. So I'll be giving you all just an overview of the management of this chronic pancreatitis. So before we go into the management of chronic pancreatitis, I think it's very important for all of us to understand the pathology, as has been very well defined by our previous speaker, and also timely recognition of this condition and confirming the diagnosis. So when we start managing the case, I think it's equally important to address the various modifier cause, as has been described earlier, like alcohol consumption and smoking. We should understand what to treat and why to treat. And of course, among the various treatment options, we should be able to select the right treatment option for each individual patient. When you see the pain mechanism in the patients of chronic pancreatitis, most of our treatment, regimes, that endoscopic or surgical treatments, are mostly focused for treating the problems at the pancreas level. So, after the disease onset, I think first 2 to 3 years, what we call it as an early chronic pancreatitis, where the patient might present to us with chronic continuous pain or recurrent pain, or sometimes acute relapsing pancreatitis. This is first within 2 to 3 years' time. And then over the due course of time, the patient will go into developing other complications. So our treatment, whatever we offer to our patients, I think it's first in early chronic pancreatitis is to treat all these symptoms, and as well as to prevent the development of these further complications. So what do we treat in patients with chronic pancreatitis? Definitely, it's pain. Almost in 80% of the patients with chronic pancreatitis, pain is one of the most frequent and debilitating symptoms. And of course, when they develop these complications like jaundice, which is due to the biliary stricture, or gastric outlet obstructions because of the duodenal stricture, need to be treated. Can we prevent this development of exocrine and endocrine function with the treatment we have? Or can we prevent development of malignancy in patients with chronic pancreatitis? We'll discuss in upcoming slides. So we have various management options, from medical, endoscopy, and surgical. The medical management, I won't be going into the depth of this, but the medical management includes various analgesic medications like non-opioids, SSRIs, tricyclic antidepressants, or gabapentinoids. But I think while we choose the medical management, it's always necessary to follow the WHO the analgesic ladder pattern in order to avoid the dependence on the opioid medications. Besides these analgesic medications, other different non-analgesic medications are also used as a medical treatment of the chronic pancreatitis, like pancreatic enzymes, which are basically used for exocrine insufficiency, but are also used for controlling the pain. Similarly, octreotide has been used. And these days, we've been hearing a lot on the role of antioxidants in controlling the pain of the chronic pancreatitis. Although there's a very existing debate on the choice of the treatment between endoscopic and surgical treatment for chronic pancreatitis, the endoscopic treatment has been well established these days, which has been used for painful, uncomplicated chronic pancreatitis. And it could be done by either ERCP with or without the use of ESWL, or even EUS has been used to treat various the complications of chronic pancreatitis. Now, I won't be going into the depth of the endoscopic treatment, but what I'm trying to show you here is, if you go and see the available literature, the endoscopic treatment has been well established and has a very good outcome in terms of whether to treat the stone clearance or the stricture dilatations or controlling the pain. However, the problems with endoscopic treatment is that they might require frequent session, which might increase the cost of the procedure, as well as if you see in depth in all these studies, significant amount of number of patients will actually land up requiring some form of surgical treatment in future. The ESG guidelines, which was published in 2018, and suggested endoscopic treatment as the first line treatment with or without ASWL in patients with uncomplicated chronic pancreatitis for the control of the pain. And they suggest to see the response in next 6 to 8 weeks time. And if it appears unsatisfactory, I think then the patient needs to be discussed in a multidisciplinary team and the surgical options have to be considered. Similarly, the recently published ACG guideline, clinical guideline on chronic pancreatitis, has also suggested the surgical intervention over endoscopy treatment only when the first-line endoscopic approaches have been exhausted or unsuccessful. So in surgical management, we have various options. We have drainage procedures, we have resection procedures, and what we call as hybrid, where we combine both the resection as well as drainage. Now, when we resect, there is definitely some risks of further developing exocrine and endocrine insufficiency. While we only drain, there is a risk of recurrence of the disease. So various factors needs to be considered. They need to be taken into consideration, like the mass in a pancreatic head, the dilatation, the strictures, the number of stones in the pancreatic duct, the complications that have developed. These all needs to be considered before we offer any kind of these surgical options. The distal pancreatectomy and total pancreatectomy with islet cell autotransplantation has been very selectively used in some very specific group of patients. The Duval procedure, the Pustos, these are not used these days, which have become more of a historical, but these are more of a drainage procedure. The modified Pusto, which is sometimes used when the head mass, head part is very atrophic and the duct is very much dilated. The resectional procedures like Beggars or bone modification or pancreatic are among the most used resectional procedure. And then comes the Frey procedure, which is a combination of both the resection, which is done in the form of head pouring, and whole of the duct is then drained into the jejunum. I think this is one of the most frequently used surgical procedure in our part of the world. Now, among these various surgical procedures, there has been comparison, and there's a good number of publications like this one, which was a CROPAC trial, which has been performed in comparing the pancreatic duodenectomy versus the other duodenum-preserving pancreatic head resection in patients with chronic pancreatitis, a multicentric randomized trial, more than 250 patients, 24 months follow-up. However, this randomized trial failed to show any obvious difference between these two different types of surgical procedures. So I can say, like choosing the surgery for chronic pancreatitis, I think there is still lack of data supporting the superiority of any one given surgical procedure over the other. So the selection of the surgical procedure has to be very much individualized. Like if a patient has any doubt of tumor, then in the head, probably the pancreatic duodenectomy would be the best option. Patient with dominant head mass but non-dilated ducts, the Beggar or bone modification could be offered. Patients with head mass with very much dilated duct, the Frey procedure might be the ideal. And when it's a dilated duct, then the head is atrophic, probably this lateral pancreatitis might be enough. The other big issue in patient choosing the surgery is the timing of surgery. As we are discussing earlier, the early chronic pancreatitis. So do we need to wait till a late period, or should we intervene in an early period and offer them surgical treatment? There's been a good number of studies which have also looked into this, the role of early surgery, and especially in controlling the pain. This one by Catherine J. et al., published in 2015 in journal Pancreas, a retrospective study of 66 patients with 3 years follow-up. So what they have been able to demonstrate that in a patients with who were operated within 26.5 months, in comparison to those patients who were operated later on, the pain control was significantly better in these group of patients. Similarly, another important study, however, it's again a retrospective study, and it was published in 2018, and they have also compared the early versus late. Here, early means those patients were operated within 3 years of the onset of the, 3 years of the diagnosis. And this study also demonstrated that the pain relief was much better, significantly better in the patients who had undergone early surgery. besides the pain control, there were low rates of exocrine insufficiency as well as endocrine insufficiency. The International Consensus Guideline, which has been published in 2019, and they have also talked on the timing of the surgery, and they have also recommended that the early surgeries should be favored over in patients with chronic pancreatitis. It's because not just only it has a good pain control and offering good quality of life. Besides this, again, the same aspects, the development of pancreatic exocrine insufficiency are lower in patients who undergo early surgery. Another issue is choosing between endoscopy versus surgery. I think in patients who present late, severe form of chronic pancreatitis, as described in imaging, probably they would be the candidate for the surgical treatment. But in patients who are in earlier phases of their disease, where you could offer both endoscopy and surgery, probably there would be this debate on choosing the right option in these patients. Now, regarding the endoscopy versus surgery, I looked into the literature. I think there are two most important randomized trials which has looked into this issue. The first one by Diet P et al., which was published in 2003. They included 72 patients, which was a randomized trial. And the other one was by Kehen et al., which was first published in 2007. And again, on the follow-up study was published in 2011. So in the first, the ERCP versus the surgical treatment was compared. And in second, the ERCP was also was combined with ESW whenever required. So both of these randomized trials have been, although these both randomized trials have been criticized in various aspects, both of these randomized trials have been able to demonstrate a very good pain control in patients who have undergone surgical treatment over the endoscopic treatment. The current evidence, the recent evidence comes from this ESCAPE trial. I think most of us are very much well aware of this trial, where the early surgery has been compared basically with the step-up approach, where in a step-up approach, the first patients are put on medical treatment, then endoscopy, and then finally surgery, versus the other group where early surgery was offered. So this was an unblinded, multicentric, randomized clinical superiority trial involving 30 Dutch hospitals and done over the 5 years period, and the follow-up month was 18 months. 44 patients in each group were compared. The results showed that the pain control, which was assessed by the HBK pain score over the 18 months follow-up, as you can see here in this graph, the patients who had early surgery has much better pain control in comparison to endoscopy first approach or a step-up approach. In the patients who were in a step-up approach group, the medical therapy failed almost in 95% patients. And then when they were offered endoscopy, even in 62% of patients in endoscopy, patients failed. So almost 30% in an endoscopy group ultimately required some form of surgical treatment. So the conclusion of this ESCAPE trial is that among the patients with chronic pancreatitis, early surgery compared with an endoscopy first approach resulted in lower pain score when integrated over 18 months. However, they have still recommended to the need of the further randomized trial, controlled trials to address on these issues. Does the surgery has any functional benefit? I think, as I have shown you in the previous some of the evidence, yes, the early surgery can control the development of deterioration of the exocrine and endocrine insufficiency. What about the prevention of malignancy in patients with chronic pancreatitis if we operate them on time? In this regards, I think there are very limited studies, but this one I found published in 2013 from Japan, and they have followed up patients of chronic pancreatitis who have undergone surgery versus on whom the surgery was not performed. And as you can see here, the patients who had undergone, who did not have surgery for chronic pancreatitis, the incidence of malignancy developed was significantly high. So this study suggests that the chronic pancreatitis is a risk factor for pancreatic cancer. And if you timely intervene in these patients with surgical treatment, probably pancreatic cancer can also be, incidence can be decreased. However, we need further studies to support these findings. Our hospital in Kathmandu, we are a tertiary level hospital. We do manage patients with chronic pancreatitis, but it's an average volume, I would say. This one study, which was published in one of our local journal, total 19 patients of chronic pancreatitis undergoing surgery. And most of our patients, those present to us are with full of pancreatic ductal stones and dilated pancreatic ducts. And the type of surgery we've been offering is most of the time, it's either a Frey or it's a longitudinal pancreaticojejunostomy. The other one on Frey from one of our fellows, published a few years back, only looked into 26 patients of Frey procedure, and we have been able to demonstrate 92% pain-free over 17 months period. So with this, I would like to conclude my talk by giving this take-home message that pain is the most common symptom that needs to be addressed in patients with chronic pancreatitis. We do have various options, starting from medical endoscopy to surgery. The medical therapy is mostly used in the initial part of the chronic pancreatitis or as a bridging therapy, and also for the treatment of endocrine and exocrine insufficiency. Surgery and endoscopy treatment, there is a debate, but I think as the experts say, it should be taken as a complementary rather than competitive the treatment options, and thus it needs to be individualized. And of course, I would like to end by saying that of course, there is a debate, but there is good evidence supporting that the evidence is favoring early surgery because of the various reasons that we have discussed. Thank you all for your kind attention.